Good evening, everyone, and welcome back to the Lipid Panel. September is cholesterol month, so I'm very happy to end the month with a LDL cholesterol made simple, we think. I am the co-chair of programming for the Lipid Panel, working with Dr. Merle Meyerson and Chloe Mativi from the NLA. The Lipid Panel was conceived as a lipid clinic conference on a national scale, reaching many of our colleagues in-house who do not have a lipid conference to discuss various cases. So this is a way for us to present cases that many of us see and take the time to answer questions. For the rest of us who feel like we're on Lipid Islands, conferences like this remind you that you're not alone. If you have cases that you want to present, please email me or email Chloe Mativi at lipid.org, and we're happy to put a panel around your cases or around your topics. The series is meant to be a monthly coming together of NLA lipid scholars and young professionals and early career lipidologists with more experienced colleagues. So I'm happy to present our expert panel this evening to discuss LDL cholesterol. We're honored to have our moderator, Dr. Dean Karalis, who is a cardiologist and lipidologist and clinical professor of medicine at Thomas Jefferson University in Philadelphia. Dr. Karalis is an expert in the field of cardiology and lipidology and has conducted over 30 clinical trials in cardiology. Dr. Karalis serves on various editorial boards, including Circulation, American Journal of Cardiology, Journal of the American College of Cardiology, Annals of Internal Medicine, and Journal of Clinical Lipidology. Our case presenter this evening is Frank Qian, who is a cardiology fellow at Boston Medical Center and clinical instructor in medicine at Boston University. We also have with us Elizabeth Beth Jackson, who is current doctorate of nursing practice and student at the University of Texas at Tyler, who began her healthcare career working in phase 1 pharmaceutical research. She's also in the Master of Science in Nursing program at the University of Texas in Austin. Beth is a certified lipid specialist and has since been a nationally recognized figure in the field of lipidology and preventive cardiology. We also have Michael Wilkinson, who's an associate clinical professor of medicine, board certified cardiologist and lipidologist, who directs the Advanced Lipid Disorder Treatment Program at the University San Diego Health. His research includes lifestyle intervention and novel drug therapies for patients at risk for cardiovascular disease, including those with cardiometabolic disease and all forms of dyslipidemia. So we have an outstanding panel tonight, and I'd like to turn the program over to Beth Jackson to start us this evening. Thank you.
Thank you so much. This is a picture of our LDL management simplified infographic, and it's very tiny, I'm sure, on your screen, but we're going to link to it in the chat so you can download your own copy of it. This was, nothing about humans is simple. Nothing about treating lipids is simple. And simplifying a complex topic like this is not simple. So this is our tool to, our effort to streamline the thought process to how we think about treating our patients. And so it's identifying the risk level and choosing the right therapy and the right therapy intensity. It's an attempt to place our guideline-directed recommendations into an easy-to-reference format for everyday practice. And I do acknowledge it will need to be revised very quickly with new therapies, new evidence, and new guidelines as they're emerging. So ideally, I could say that the next iteration or the next update would perhaps integrate biomarkers such as ApoB and lipoprotein A. But right now, this is up to date with our guidelines and our the updates that have come forward as of 2024. So, and I'll hand it over to Frank for the case presentation.
So thank you, Beth. And I thought we could sort of put some of those features in that that statement into kind of a real life patient. So we have Mr. P, who comes to see you in lipid clinic. He's 58 years old. He does not routinely see a doctor, so he's a little unsure of his past medical history. He thinks he might have been diagnosed with type 2 diabetes at some point. He has a history of hyperlipidemia, but we'll kind of talk about sort of his treatment history. He is married, he has 3 children, and he's originally from Mexico, but has since lived here for most of his life. He does have a family history of cardiovascular disease in his father, who died from a myocardial infarction. His father was a lifelong smoker, also did not seek out regular medical care at the time. His social history, he was a former smoker, and he did have a visit to the emergency room about 4 years prior to his current visit for an episode of chest pain. He has a lot of musculoskeletal pain. Partially from his prior career in welding, so he's fairly inactive at his usual baseline. And he does follow a traditional Mexican dietary pattern. So he's not currently on any medications. And regarding sort of his, why he came to see you, he doesn't endorse any ongoing chest pain, but he does say that, over the past couple of years, he's noticed some intermittent dyspnea on exertion. And then, when he was previously seen after that ER visit about 4 years ago, he was prescribed simvastatin by his primary care physician, but he has since discontinued that due to statin intolerance.
So Frank, just as maybe, I don't know if you have any more information on the case, any more details on the dyspnea on exertion? How often is it occurring? Does it occur with minimal exertion? Has it progressed? And any more details on statin intolerance?
Yeah, so I would say that, his dyspnea is provoked by fairly light exertion. He's usually fairly inactive. And I think, part of that he attributes to just, gradual weight gain and sort of getting older. Regarding the statin intolerance, he's not entirely sure of exactly what the symptoms were. He recalls maybe, having fatigue after starting the statin, but it was also partly, motivated because he had family members who were prescribed statins and sort of had side effects. And, from talking with them, he sort of became more suspicious about statin therapy and decided to self-discontinue.
Right. And I guess, we've all seen in these patients, it's not that uncommon that patients have a remote history of statin intolerance and really can't recall what medications they were on or exactly what the side effects. And it makes it a little bit more challenging when we think about re-challenging patient with statins.
Great point. Yeah. So I'll continue with the physical exam. So he does have an elevated BMI at 38, which would classify him as having class 2 obesity. And his blood pressure on, multiple kind of rechecks were persistently elevated, sort of in the 140s to 150s over 80s. He doesn't check his blood pressure routinely at home. And on a physical exam, it's fairly unremarkable other than just some trace peripheral edema. We did get a fairly comprehensive set of blood work when he came to see us in clinic, and I'll show some of the numbers there, but some things to point out: his triglycerides were elevated at 255, HDL was low, and then he did have elevated LDL as well as non-HDL. His ApoB was also elevated at greater than 140 milligrams per deciliter. His Lp(a) was also quite elevated at 246 nanomoles per liter. HSCRP was elevated at a 4.5, and consistent with his sort of self-reported history of diabetes, he does have an elevated A1C at 7.6%. And eGFR was calculated to be 52, which places him in stage 3A CKD. And then, he was sort of curious about, given his premature family history, what his sort of next, future risk of cardiovascular disease is. And, we show here sort of based on those lab work and his other clinical risk factors, 2 calculations. The first is from the pooled cohort equation, which shows a 10-year risk of 29%. as well as a lifetime risk of 69%. And then because, the prevent equation has become introduced now as an alternative way to calculate risk, we also have a 10-year risk for that, calculating to be about 22% and estimated 30-year risk of 51%.
Yeah, and I think this is kind of what we see where the prevent risk score gives you a slightly lower risk than in the pooled cohort equation. But I think irrespective of which score, I think we'd all agree this is a very high risk patient. So I want to go back to the previous slide, and maybe Mike, we can get you into the conversation. This is somebody who clearly has a lot of risk factors and a lot of things to address, and we know he's high risk. How do you approach this patient when you see him in the clinic and he needs medication? This is clearly going to be polypharmacy along with lifestyle changes, but so that you don't overwhelm the patient, how do you approach all these different risk factors, diabetes, cholesterol, hypertension? Do you address one at a time from a medication and lifestyle? Do you start on multiple medications targeting each of these risk factors? How would you approach this patient seeing the first time in clinic?
Yeah, thanks, Dean. I think that clearly this patient, as you said, has a lot of cardiovascular risk factors, and I'm really worried about him. He's coming in with symptoms. I mean, on top of everything else that we're seeing, all of these risk factors, all these abnormalities on his labs, he's having dyspnea on exertion, clearly a very high risk patient. And I think in making decisions in collaboration with the patient about what to do next, I think it really comes down to the relationships that you have with the patient, the ability to explain their risk. And I think all of the information that we're reviewing together is useful to include in that conversation, from individual high-risk lab features to those 10-year estimations of risk, putting it in the context of things like his family history. But we want to present this in a way that he understands the risk and understands our concern. And then we can start to reach for some of the therapies that we think are going to make the greatest impact. So like you said, there's a lot that needs to be addressed here. So, choosing things like lipid-related risk, metabolic-related risk. I think we're going to have to work with him on, what might he be willing to start out with? Is it 1 pill, 2 pills, or injectable therapies even on the table? And that's where I'd start the conversation with him.
And Beth, what are your thoughts about how you approach this patient when you're seeing them in the clinic?
I completely agree, Dr. Wilkinson, with your approach, and really earning the patient's trust. So going forward, we're not going to lose him to follow-up. He's already lost to follow-up on a separate occasion. I think, and to point out, a lot of this is modifiable. Well, some of it's not, but like the LPA, but we've got every patient, every time we've got to talk about diet and exercise. And I think that's going to be a conversation that's going to build over time. Even, I know we don't have time in the clinics, but even if we have 2 or 3 sentences that we can get in, or handouts on the Mediterranean diet or the DASH diet, that's going to impact a lot of these results. And as far as the medications, the shared decision-making with the patient, and really being judicious about the choices of medication. And the one, thinking about in terms of do no harm, like we do, but do the most good. Like really be conscientious about, if we give a patient a medication to benefit one comorbidity, we're not insulting another one. Like we don't want to give him something to control blood pressure that might elevate his triglycerides or his weight. So, so there's a lot of considerations to take when we're addressing this patient.
Yeah, I mean, we're really, as we dive more into the case, and we'll get into a little bit later, and I'll ask you how you would treat this patient's blood pressure, their cholesterol, their diabetes. I mean, based on guidelines and with more aggressive goals, you may be talking, 2, maybe more medications for blood pressure, 2 medications at least for his lipids, or more, at least 2. And we get into this difficulty of polypharmacy and expense. And I think you bring up a good point about importance of diet and exercise. But I want to get back to, and Frank, I want to ask you early on, he has this symptom of exertional dyspnea, and we know that diabetics often don't have classic anginal symptoms. So, he may ask about getting into an exercise program, but how would you work up the shortness of breath? Would you do any imaging? Would you do any cardiovascular testing? How would you approach this patient from a standpoint of his symptoms to try to rule out any obstructive coronary disease?
Yeah, thanks, Dr. Karalis. I think something you mentioned earlier is, but because of his diabetes, whether these symptoms are just an anginal equivalent. So I think, ruling out obstructive coronary disease is sort of highest on my list of things to do to kind of tease out what's causing his symptoms. I think for someone like him, relatively on the younger side, a coronary CTA would be a very reasonable option. It sort of would tell us about, obstructive disease, but also allow us to kind of quantify the amount of plaque he has, both, non-calcified as well as calcified plaque. And, I think, as someone who, based on my interactions with, sort of is suspicious or slightly distrustful of the, medical system, sometimes it takes, having that visual, stimulus of, seeing how much disease there are in his coronary arteries to, make him realize that, how high risk he is and sort of be more open to accepting, more aggressive medical therapy. I think, just based on his other history, he is a long-term smoker. So I think, evaluating for COPD, that would be important, getting an echo to make sure he has a normal ejection fraction, making sure he doesn't have any, significant valve disease that we're missing out. But I think the first thing on my to-do list is probably making sure he doesn't have a lot of obstructive coronary artery disease.
Yeah, and I think that's exactly where guidelines are going now. Is imaging with coronary CTA in symptomatic patients. We have a high suspicion that there's underlying coronary disease. And I think you hit the nail on the head. It not only tells you whether there's any obstructive disease, but also gives you an idea of total plaque burden, which will help determine how aggressive you really need to be with guidelines for blood pressure, cholesterol, and for diabetes.
Yeah, I think that just like you said, Dean, I think, and Frank, the coronary CTA, the test of choice in this patient, we're talking about non-invasive ways of assessing for coronary artery disease. I think it's, that's in current recommendations, and it's most likely going to perform better than other non-invasive stress testing. I did want to say, as follow-up to Beth's point about avoiding harm with therapies, we can also look for opportunities where we can address more than one risk factor with a therapy. We might get more than just one thing out of a drug, for example, a GLP-1 receptor agonist. So we're going to treat his diabetes, but we also know that there's cardiovascular benefit in patients with coronary artery disease and diabetes, or patients with diabetes, period. We also have data for people without diabetes with obesity and coronary artery disease where there's benefit of semaglutide. So there's overlap there between a drug that's treating the metabolic risk, the diabetes, and also has known benefits in coronary artery disease. So that's another way to try to get the most out of the therapies that we do recommend up front for this patient.
Yeah, those are all great points. So now we have our first audience participation question. So I'd like the audience to just go ahead and answer the question. What would be the LDL target or threshold for this patient? How would you handle it? Less than 55, less than 70, less than 100, or I'm not sure. So we'll give it just a little bit more time and see what most of the audience feels. So we have close to almost 90% would go at least under 70, and just over half would go under 55. So I think we got a pretty aggressive group, which is great. All right. So Beth, I'm going to ask you, since you were the lead author on this paper, which was how do we simplify LDL goal attainment? And maybe you can talk a little bit about how this fits into what the NLA's recommendations are and how this matches what some of the guidelines are from other professional associations.
Great, thank you. Yeah, so the risk categories are identified here, and the X's are for Mr. P. We can't put him in the very high risk category at this point because he's not had an ASCVD event. However, I think we are all on the same page that this is a pretty high risk patient, and we want to treat the LDL aggressively and not wait for him to have an event. So getting his evaluation and identifying his, I also thought about Mr. P when he had that ER visit for chest pain. How did they rule him out just by lab work? Did they do any? It doesn't sound like any functional studies were done or imaging. So, in my head, maybe he had some kind of event, but so he falls into the high risk category at this point. So the LDL objective, as we have it in our guidelines right now, is less than 70, but this has all pointed out that I think most of us would be a little bit more aggressive with him.
Right, and I think the point is too, and I think sometimes we interchange the word goals and thresholds, but this is really a threshold, so there's no harm in going too low. The harm is only leading this patient with too high of an LDL cholesterol. So I think under 70, under 55 are good thresholds to get them at least to that low and even lower. So I'm going to ask, maybe Mike, you can talk a little bit about, we have LDL, which is what the NLA is trying to simplify things, but we also have some secondary goals of non-HDL and ApoB. So maybe you can talk a little bit about, how we incorporate non-HDL and ApoB, which ones may be better markers, especially in patients with diabetes, and how we would incorporate it into this patient.
Yeah, that's a great question, Dean. ApoB and the NLA has a recent statement on the use of ApoB in clinical practice, and so I recommend to our audience look at the ApoB expert clinical consensus from the NLA. The table that you see on the screen is from that document, and it organizes non-HDL cholesterol and ApoB into risk profiles. And you can see the corresponding LDL cholesterol when we're talking about treatment thresholds using LDL-C, non-HDL-C, or ApoB. Non-HDL-C is a way of estimating the cholesterol content of the entire family of atherogenic lipoproteins. So if you remove HDL particles from the equation, you look at the cholesterol content of everything else, including LDL cholesterol, that gives you your non-HDL-C. And in our patient with diabetes and in other individuals with either other forms of metabolic disease or in other scenarios, we often do see a discordant elevation in non-HDL cholesterol because those patients have a greater number of triglyceride-rich lipoproteins like VLDLs and IDLs. Small VLDLs, IDLs, this entire family of ApoB containing lipoproteins beyond LDL that contribute to a non-HDL-C can contribute to risk of atherosclerosis. And so we often see, as is the case for this patient, a discordantly elevated non-HDL cholesterol and ApoB because of that excess in circulating triglyceride-rich lipoproteins. I think the way to remember the concordant values, or what you would typically expect in this relationship between LDL-C and non-HDL-C, is that non-HDL-C is usually about 30 milligrams per deciliter higher than LDL-C. So you can see that if you go right down the table here, the treatment thresholds also reflect what we usually see when LDL-C and non-HDL-C values are concordant. In this patient, we want to use non-HDL-C and ApoB to think about that residual risk or additional risk that we might miss if we looked at LDL-C alone. And I think it's There's data to suggest that these measures are particularly useful in those situations where there's discordance, where non-HDL-C is higher than you'd otherwise expect for an LDL-C, where ApoB is higher than you'd otherwise expect for an LDL-C. So useful, especially in this patient's situation. And with regard to using these values as treatment thresholds, these are recommendations from the NLA. And I think, look at this, pick your LDL-C threshold that you're thinking about, and then look to the right and look at where we should be trying to get this patient's non-HDL-C and ApoB. All are useful both before treatment and in measuring response to therapy.
That's a great summary. I'm going to move on now because I want to make sure we have plenty of time to how we're going to treat this patient. But Beth, we know this patient's Lp(a) is high, so maybe you can talk a little bit about the NLA guidelines and their paper on Lp(a) and what's considered high risk and what we can do about that.
So the lipoprotein a is, we know, of a strong driver of atherosclerosis, and the cutoffs are here, where we start considering high risk. We did have his measured in nanomoles per liter, and it was, I believe, 267. So it is genetically driven. He's not going to be able to impact his lipoprotein A by diet and lifestyle. And unfortunately, there are no therapies directly impactful to the lipoprotein A at this point that are indications. We do have so many medications in the pipeline that are really close, and I'm very excited about them from our pharmaceutical friends. So right now, what I do with patients with elevated lipoprotein A is it's a risk enhancing factor, right? It's going to increase the risk. It compounds their risk, and he's already very high risk. And so I want to plummet, plummet the LDL cholesterol, get his diabetes under control, get his blood pressure under control, and really make strong, impactful moves with Mr. P. We do know that the PCSK9 monoclonal antibodies have an impact in lowering LPA between 25 and 30%. But it's not an indication, and we don't, is that improving his risk is still a question.
Right, so it's a risk enhancing factor, and it should be measured at least once in everybody's lifetime. And we're going to talk a little bit more because there's an audience response question about Lp(a), but that's, I think the key is measure it at least once in everybody's lifetime, and it increases risk above and beyond other traditional risk factors. So again, this is just kind of a summary of where this patient is at baseline. And we now have the second audience response question on how would you treat this patient? So again, recommend a trial of lifestyle first, re-challenge them with a different statin, add ezetimibe or bempedac acid alone or in combination with ezetimibe, jump to a PCSK9 inhibitor, or again, I'm not sure. So if the audience can respond to this, and then we're going to get the panel's opinions on how they would manage this patient who's had some issues with statin intolerance. We need to have some music in the background next time to sort of occupy the time. There we go. So again, small percentage. The majority would re-challenge them with a different statin, and about a quarter would add a PCSK9 inhibitor. So Beth, I want to start first, and you talked a little bit about lifestyle, and we'll make the assumption that the patient had a coronary CTA that showed no obstructive disease. So there's no contraindication to exercise. We know we're going to do pharmacologic therapy, but as a start, what kind of diet would you recommend? Would you recommend a keto diet if he brought that up? What about exercise? What recommendations would you give him to start when you're also about to have the conversation about pharmacologic therapy?
That's an excellent question. Thank you. So he's disabled, right? Getting him to move is going to be challenging. So I'm going to talk to him about doing small steps of getting his body more active. the little peddlers that you can put at your couch, just walking more, maybe pool therapy, aqua therapy is really, really good. So just, we're going to talk in terms of, let's just move more. I don't expect him to go start running 3 miles every day. Like that is going to be an unrealistic expectation for him. Diet wise, the Mediterranean and the DASH diet are going to have the most impact, I believe, for this gentleman. In the DASH diet is dietary approaches to stop hypertension, and so it lowers blood pressure as much as a starting dose of blood pressure medications, and often low sodium diet, that kind of thing. And also those should impact his triglyceride levels as well, that combination of diet and exercise. And so working on his weight, getting his weight down, losing, there's a mantra that's out there now. It says treat obesity first, because when we treat obesity, we have the ripple effect of treating all these other comorbidities, the sugars, the blood pressure, sleep apnea potentially, which might be something we would look for in him. And so I would approach it with those 2 diets. I always have handouts readily available to hand to the patient, and hopefully they make it to the car and into the house when they get home. So keto diet is, I would strongly advise him to avoid the keto diet. I have seen LDL levels go up exponentially in some people on that diet, and these are the biomarkers that we're trying to improve. So I don't think the keto diet would be beneficial for him.
Right. I think those are good advice. So Mike, let me ask you a question. So the majority of the respondents would re-challenge this person with a statin. So guidelines would recommend at least a moderate or high intensity statin, but he's got this history of some kind of a statin intolerance with simvastatin. How would you approach this with a re-challenge? Would you go to a high intensity statin? Would you start with lower doses? How would you approach re-challenging this patient given his history?
I think that it is definitely worth having that conversation with the patient. We know that he's tried simvastatin sometime in the past and had some form of statin intolerance. And we really can't label him or give him a diagnosis of statin intolerance yet, according to some accepted definitions for statin intolerance. I recommend to the audience looking at the statin intolerance statement from the National Lipid Association. It's a really great document that not only provides definitions for statin intolerance, but a lot of very useful clinical guidance. There's information about statin intolerance in this LDL Made Simple document too. So some good resources there from the FNLA. But I think that we really want to get him invested in this. That's the first step, to share with him that this is our recommendation. We think that he'll benefit from another challenge of a statin medication. These are medicines with a great track record. We know they reduce risk of cardiovascular events, MI, and stroke. And we can often find a different statin that somebody can tolerate, even if it's at a lower dose. So the other issue is to look specifically at the fact that he was treated with simvastatin previously, and simvastatin we know has a lot of potential drug-drug interactions. So could he have been on simvastatin and then had been prescribed a medication that caused a drug-drug interaction, and that led to muscle symptoms from the simvastatin? If we're going to use high-intensity statin therapy, which I think is where we'd like to get the patient if he can tolerate it, we're down to atorvastatin 40 or 80 milligrams or rosuvastatin 20 or 40 milligrams. But what I'll often do in patients like this is start out with a lower dose of atorvastatin or rosuvastatin to make sure they can tolerate a moderate intensity statin. I want them to have a good experience with this repeat attempt at statin therapy. And if they can tolerate even a 5 milligram dose of rosuvastatin or 10 milligram dose of atorvastatin, those usually lead to a 30 to 50% reduction in LDL cholesterol, which would be a great starting point for him. And if he has a good experience, he doesn't have any muscle symptoms or other side effects, then I think that could be a really successful way of getting him onto a statin medication.
Yeah, I think those are all great ideas. And then again, making sure that we recheck the LDL 4 weeks after, or soon after and bring the patient back so we don't lose them to follow-up.
And I would also add, if I may, that I completely agree with those comments, but ruling out contributing causes to statin intolerance, like checking his thyroid level, making sure he's not hypothyroid, vitamin D deficiency. He does have some renal impairment, and that can contribute to it. Check his liver function tests and get his diabetes under control. Is he drinking a lot of alcohol? That contributes to statin, the perception of statin intolerance. Does he love grapefruit juice, right? Is he drinking a ton of grapefruit juice, which can increase the area under the curve and contribute? And then, he's got some family history here. So potentially, I mean, I'm not recommending necessarily that we check the slow COD1B1, but there's a gene that actually does show that it affects the statin transport if you have an abnormality there. So there's some things to look at that is a good talking point with the patient. Even subclinical hypothyroidism has been shown in some instances to contribute. So it gives them a little bit more confidence. And the other way I massage the conversation is I don't go into great detail of lipophilic versus hydrophilic, but oftentimes I'm like, oh, well, this one's metabolized a little bit differently. Let's see if you can tolerate that one. So maybe I'd go with rosuvastatin over atorvastatin because to get to the hydrophilic side. So
sure, it's all the way you frame it, right?
right.
So anyway, we have three great clinicians here, and I'm certain that you've all gained the patient's trust. He has non-obstructive disease. You've gained his trust. You've talked to him about lifestyle, what exercise he can do. We've started him on a moderate intensity statin. And Frank, I want to pose the next question. Now, we know he has diabetes. We know he has hypertension. So the question then is, what do we do about his blood pressure? Now, new guidelines recommend he should be well under 130 over 80. Do we give him a trial of lifestyle and recheck his blood pressure? Do we start him on blood pressure medications during that office visit? Guidelines recommend maybe starting 2 medications if you need much more of a significant. So how would you handle, now that you've gained this patient's trust, how would you manage his hypertension at this point?
Yeah, thank you, Dean. So, I would first say that, based on his at least in-office measures, I'd like to at least, also have some measurements done outside the office just to kind of corroborate. But assume, those are also elevated, to a similar degree. I would say, his blood pressure is really elevated to the level that I would go ahead, as long as the patient is amenable. I would say, we should start you on at least one agent, sort of see how you do, give lifestyle a try. And I would say, given his diabetes and obesity, I think Dr. Wilkinson alluded to, something like a GLP-1, maybe if he were to lose some weight with a GLP-1 receptor agonist, that could, potentially bring his blood pressure down, even without adding further medications. But I would say, I think, his level is at a degree, I would have a very low threshold to say we need to start pharmacotherapy while we also work on, lifestyle measures as well as other medications that could help you lose weight and control your blood pressure, in addition to, making sure that his out-of-office blood pressure is also, similar, and he's measuring his out-of-office blood pressures.
And it's also important to make sure that, and I know the audience and I know all you do it as well, is make sure that we check a urine to creatinine albumin ratio. He does have, some underlying chronic kidney disease. That may also change your decision with regard to diabetic medications, whether maybe a GLP-1 or maybe even an SGLT2 inhibitor. So Mike, how would you handle the diabetes? Now, we've just started him on a statin. We've just put him on, say, some blood pressure medicine, maybe an angiotensin receptor blocker. Are we going to hit him with a third medication for his diabetes now? Are we going to take a step back? How would you handle this, in the clinic?
I think that, we've got some great treatment options for diabetes now that really have benefits that go beyond diabetes, like we're discussing here, the GLP-1 receptor agonists, SGLT2 inhibitors. The diabetes treatment guideline recommendations have been updated recently such that, not every patient necessarily needs to start out with metformin before going on to, using some of these drugs that have proven cardiovascular benefit. In his case, I would frame the conversation around those benefits. I found that really useful in my practice, that we're not just treating a number, we're not just lowering your blood sugar. That's not what these drugs are. These are drugs to lower your risk for things like a cardiovascular event or like progressive kidney disease. The GLP-1 receptor agonists we've been talking about, I think really those have a lot to offer this patient, but there's some practical considerations too. You need to have that conversation with the patient around potential side effects, nausea, other potential GI side effects, his comfort level with giving himself self-administered subcutaneous injection on a weekly basis. Although there is also the oral GLP-1 therapy. But then if his preferences are really clearly more around oral therapy, or that's what he's comfortable with right now, Dean, you mentioned the SGLT2 inhibitors, which would be fantastic for him in terms of diabetes management, risk reduction from a cardiovascular standpoint, and kidney protective effects.
So I think we've pretty much all decided. I mean, we have to write this patient's at very high risk, and he will need polypharmacy along with really aggressive lifestyle changes. So we know his LP(a) is significantly elevated, and this is the last of the audience response question. So if we can bring this up, how does this patient's elevated LP(a) affect your treatment plan? It doesn't change my treatment plan. I treat all other ASCVD risk factors more intensively, more likely to prescribe a PCSK9 inhibitor, or I'm not sure. So far the audience has not chosen I'm not sure for any of the first two. So we have a very attentive and well-educated audience. Let's see what they answer for this question. So again, kind of a little bit more favoring to more aggressive, but clearly a good proportion of much more likely to prescribe a PCSK9 inhibitor. All right, let's go back to this one again. So Beth, let's talk a little bit about this patient's LP(a). And I'm going to kind of give you the scenario. He's gained your trust. He's right now on a moderate intensity statin, say a high intent rosuvastatin, 20 milligrams a day. His LDL cholesterol has fallen to about 80 milligrams per deciliter. His ApoB is still higher, probably about 85 milligrams per deciliter. He's lost a considerable amount of weight on his GLP-1, and his hemoglobin A1C is now less than 7%, and on an ARB, his blood pressure is controlled. So how would you handle, given the options that we have now, to further lower his LDL cholesterol to goal of at least under 70, recognizing that his ApoB is farther from that goal? We've got ezetimibe, we have bempedoic acid alone, we have PCSK9. How would you approach this patient? He's comfortable now injecting with his GLP-1 and his elevated LP(a). What would you do next with regard to more intensive lipid-lowering therapy?
Well, I agree with the audience. Thank you on that. B and C are my favorite answers for this question. I alluded to treating all of his ASCVD risk factors more intensively earlier, but as far as intensifying his lipid-lowering therapy, I'm also very happy to hear that we're making progress with him. But for intensifying his lipid-lowering therapy, when you consider ezetimibe, we're about 20%. So reduction is what we expect. Same with bempedoic acid, and the combination of the two is about 38%. When we look at the PCSK9 inhibitors, much more robust drops, and we get the benefit of the slight improvement, the 25 to 30% improvement in lipoprotein A, even though we don't know really what that means clinically at this point. We like to see that number go down. So I would definitely have the conversation with the patient about going on a PCSK9 monoclonal antibody.
And Frank, do you agree with that as well? Would you go with the PCSK9 to get the greatest bang for your buck in lowering the LDL and the LP(a)?
Yeah, I think that's very reasonable. Like we were saying earlier, those there's not necessarily a floor of LDL that we have, we're trying to hit. We're really trying to get as far below those thresholds as possible. And you can argue, he's someone who's, even though he has non-obstructive disease, he's probably higher risk than most of your sort of usual primary prevention. He's sort of, in between a primary and secondary prevention population. And I think that, if cost and, the fact that he's already taking an injectable, a second injectable wouldn't be a barrier to him. I think that's very reasonable to get this additional kind of LPA lowering. And we know that, that'll have an additive benefit in addition to LDL lowering.
Mike, I'm sure you'll probably agree, so I'm not going to ask you. We can be like America's Got Talent. You can be the third judge that agrees, and we've got a winner. But we've got about a minute left before we go. But I'd like you, Mike, if you can comment a little bit about the fact that LPLA is almost all genetically determined and the recommendations about cascade screening for this patient.
Yeah, I'd be happy to, Dean. Thank you. And I just wanted to really emphasize one thing before we leave the PCSK9 inhibitor idea, and that is that in this patient and in all the patients where we use PCSK9 inhibitors, we should really think about the benefit being primarily related to the LDL cholesterol reduction. Again, that's really our primary target of therapy for this patient. And from the clinical trials, we know that it's the 50 to 60% reduction in LDL cholesterol that we get with PCSK9 inhibitors that is the driver of risk reduction. Whether Lp(a) lowering of 15 to 20%, or what we typically see with PCSK9 inhibitors, translates into additional ASCVD risk reduction. There are some hints of that in post-hoc analyses from clinical trials with the PCSK9 inhibitors, but like Beth said earlier, we've got more potent targeted LPA lowering therapies that are in development. In terms of cascade screening for Lp(a), we mentioned already that the NLA's recent statement on lipoprotein(a) recommends testing Lp(a) in all adults at least one time. And we really especially need to be performing cascade screening among affected patients and their families. So testing for Lp(a), framing this in our conversations with patients as an inherited risk factor for cardiovascular disease that everybody in your family should be tested for, I think is a really important part of the conversation that we have to have with patients around Lp(a) every time. And, it's been really gratifying for me in practice is to have that conversation with patients, and suddenly a lot of things make sense for them. They've had this strong family history of cardiovascular disease, multiple affected family members, they have premature disease. And now we can point to something that's likely an important part of why their family has had to face such significant burden of cardiovascular disease. So using Lp(a) to refine our estimation of risk, including among families, I think is critical.
So I think these are all great comments, and I really want to thank our experts for discussing this case. I just want to remind everybody that the infographics that Beth was lead author on, that's good for also your staff, for nurse practitioners, PAs, nutritionists, anybody who manages and takes care of patients to try to improve their risk factors. Now, we have some questions here, and I'll pose this. One of the questions is the European guidelines, which just came out, are a lot more aggressive than the NLA guidelines, the American Heart Association ACC guidelines. I guess the question that the audience participant was asking is, why are the Europeans more aggressive than us? So maybe we just haven't caught up yet, but our guidelines will be coming out later this year, early next year. But Beth, maybe you can tell us how you incorporated when you developed these guidelines from the NLA, putting together current guidelines, both from the US, from the National Lipid Association, and from the Europeans. How did you incorporate all those guidelines into something that's a little bit more simpler for clinicians to deal with?
Okay, so these are, we were very specific about this needed to be in accordance with our current guidelines. And so we took the current guidelines, the updates that have come out from ACC on acute coronary syndrome. You know, we've had some incremental updates over the years and wanted it to stay very crisp, clean, targeted to LDL. You know, I said earlier, I think that the next update to this this tool is potentially going to be have more aggressive guidelines. I was happy to see the ESC getting a little bit more aggressive with their LDL control, and we've all talked about how we want this gentleman to have a more aggressive target than the threshold of getting under 70, but no floor to the LDL. So we kept it as precise to what is recommended by the NLA and the guidelines as we could, or made sure of that. It was edited to the extensively, looking and comparing it to our other documents and the ACC guidelines and so forth.
So another question that came in, and Mike, I'll pose this one to you. And there's no right or wrong answer here, but the question is, why would we choose, or why do we talk about coronary CTA in evaluating this patient's symptoms versus a stress test? And when would you consider a coronary CTA? When would you consider a stress test? And maybe what are some of the differences that they may offer in both prognosis and in estimating plaque burden?
So both stress testing and coronary CTA are included in recommendations for evaluating the patient with chest pain. And by stress testing, that includes everything from stress echocardiography to nuclear imaging. And every one of those non-invasive tests has their own sensitivity and specificity. Coronary CTA usually does better than those other non-invasive techniques for making an accurate diagnosis of obstructive coronary artery disease. And I think it is very quickly becoming the preferred non-invasive test for a patient in this situation. That said, there are limitations to coronary CTA. It's a test that requires an IV, iodinated contrast. Depending on the scanner, patients may need pre-medication to lower their heart rate. So beta blockers usually use nitroglycerin for vasodilation to improve image quality. So the patient has to be able to tolerate those aspects of performing a coronary CTA. There can also be some limitations in getting accurate evaluations of the lumen of the coronary artery if there are a lot of dense calcifications. So a lot of dense calcified plaque in the coronary arteries can create imaging artifact that can make it difficult to conclusively rule in or rule out underlying obstructive disease. But the other benefit of a coronary CTA in terms of risk stratification is that we get a calcium score back every time. And there's a lot of good data behind risk estimation using coronary calcium scoring. We're also learning more and more about the use of other plaque characteristics, plaque morphology, plaque burden. A lot happening right now in the way that we might be able to use those other elements of plaque from a coronary CTA in primary prevention, high-risk primary prevention, in getting patients onto the right therapies to lower their risk as early as possible.
Great explanation. And Beth, another question that came in, I'm going to pose this to you. And you mentioned it briefly about the ongoing trials with Lp(a) lowering drugs. And there's at least 5 now that are being investigated, 3 in large outcome trials, 1, which we're hoping to get some answers soon. Maybe just a kind of brief overview of maybe the trial that's going to be the trial that's most likely to complete soon, and what patients are enrolled, if you're aware, and what kind of Lp(a) reductions are we seeing with these medications?
Wish I could show you. Let me, thank you. I'm going to pull a slide up that has it summarized, if I can do that. I don't know if I'm able to share.
Maybe I think you just kind of maybe just kind of give us because
Slide or not, but so the Horizon trial is pelacarsen, and that's a liver-targeted ApoA antisense oligonucleotide, and that's in phase 3. We're seeing up to about an 80% reduction is olpasiran, which is there's 3 actually that are small interfering RNA. The olpasiran is close; it's in phase 3, and lepodisiran, if I can say it correctly. But the small interfering RNAs we're seeing over 95% reduction in LPA. And so we've got, those are the closest. We've got, there's another small interfering that's done with phase 2. And then there's muvalaplin, which disrupts the covalent binding of ApoA to ApoB. It basically prevents the assembly, and that's an oral daily drug. We're seeing about it up to 65%. That's still in phase 2. And then we have the CRISPR technology that's only been given to non-human primates, but gene science, but it's in phase 1. So those are that's this kind of a quick summary of the LPA drugs that are coming. So I think pelacarsen and olpasiran are the 2 that are closest.
And Dean, I just also want to bring up lipoprotein apheresis, which we haven't discussed, but it is an FDA-approved treatment for lipoprotein(a) in people with FH, high Lp(a), and a history of cardiovascular disease. And, not something that we would get to right away with a patient like this, but we should have it somewhere in our minds as one of the currently available approaches to Lp(a) while we await the results of the trials that Beth is describing.
So I think we have probably time for just one more question, and Beth, I'll throw this one back to you. The question has to do about VLDL cholesterol, and how does VLDL cholesterol impact cardiovascular risk? Do we measure it? Do we use triglycerides or non-HDL as a surrogate of remnant cholesterol? But maybe you could just spend a minute or two and tell us in real world practice, how do we address the risk associated with these, triglyceride-rich atherogenic lipoproteins?
So we're talking about the remnant cholesterol.
Yep.
Like we talked about having this included, but can we go back to the slide that has the remnant on his lab results? So I think the biggest impact on the remnant cholesterol is going to be getting his blood sugar, his lifestyle better. Let's go up a couple more slides. It has the calculation on it. Yeah. There we go. So you can see the remnant cholesterol, his is around 51, which is total cholesterol minus HDL-C minus LDL-C. And that's how we estimate it. Over 30 is considered high risk. He's got that, this whole pattern of him is this obesity, this diabetes that's uncontrolled, the adipocytopathic dyslipidemia, which is that high triglyceride, low HDL, high remnants, high LDL cholesterol, high non-HDL. So as we're globally impacting his multi-risk factors, we should be seeing the VLDL decrease.
All right, so I'm going to jump in here because we can go on and on. I want to thank the panel for doing a great job. Mike, Frank, Dean, and Beth, it was great. We touched on a lot of subjects, and as I said, we can keep going on and on. I just want to highlight that the LDL Made Simple infographic you can be using in your clinics, that your medical assistants could be filling out, and then presenting it to the clinician. So I think it's a great piece of work and something we can utilize on a daily basis. So the other thing I want to point out, the lipid panel is back. We meet the last Tuesday of every month. Next month, we're having a great panel, October 28th, and the title of that panel is A Complete Unknown. So I don't know what it is, but I know we have great faculty, and you'll have to all figure it out what we'll be talking about. So thank you for tuning in tonight. A lot of the information was put in the chat for everyone to utilize references. So thank you to the panel. Great job, and everyone have a great night.